Welcome to Lincoln American University.
Today's topic is hypertension. We'll be discussing about definition of hypertension types, basic evaluation of hypertension, what are the non-pharmacological treatment, and what are the pharmacological treatment of hypertension. I'll try to make this presentation very short and precise. Hypertension is the cause of death, constituting around 31% worldwide. Most of them are from low and middle income countries, and 39% of population have hypertension. I know that most of us are from India. So in India, around 29% population have hypertension. Just to go to the second slide, I would just like to just make it more interactive. The attendees have completely gone off from my screen. I don't know why, so I cannot pick up anyone. Anyhow, so I will just like to ask the question. If anyone can give me the answer. Just a second. Okay. So what do you think? What's blood pressure? I'll just give you a little bit of idea about it. Blood pressure is cardiac output times systemic vascular resistance. And cardiac output is stroke volume times heart rate. I would just want to ask, what do you think, what is stroke volume? If anybody who is just reading physiology these days, what is stroke volume?
Cardiac output into heart rate.
Okay, that's great. Cardiac output into heart rate. So if you see the slide, cardiac output, it's stroke volume times heart rate gives you cardiac output. So my question was, what is stroke volume?
So the amount of blood that is in per beat. So the amount of blood that is ejected after one contraction is the stroke volume.
Okay. I think you're going through my slide. No. Can you just explain to me in your language what's a stroke volume? What is that volume basically? I got your point, that is the amount of blood pumped by the left ventricle in one contraction. But what is that blood? What it is called in other terms? Okay, so basically stroke volume is the end diastolic volume in the ventricles. What does end diastolic volume means? You might be knowing about this, the physiology. There's a systole and a diastole. Diastole is when the heart relaxes. So stroke volume basically is the amount of blood at the end of ventricular diastole, which is about to get ejected during systole. So end diastolic volume basically gives us the amount of blood which is left in the ventricles at the end of diastole. And stroke volume depends on cardiac contractility and the venous return. That means the stroke volume can drop if somebody has cardiac dysfunction, systolic heart failure, or the venous return is poor, let's say in hypotension, when you are dehydrated. So the hypotension part, when the venous return is low, the blood in the left ventricle is low, so the stroke volume is dropped. And then the systemic vascular resistance, which is the resistance offered to the blood flow by the systemic vasculature. So in other terms, blood pressure is cardiac output into systemic vascular resistance. Can somebody tell me what is the normal value of cardiac output? How much is the normal value of cardiac output? Anyone?
4,900.
5 liters.
It's around 4 to 8 liters. So cardiac output is around, and what is the normal value of stroke volume?
70 ml, sir.
It's around
70 to 75 ml.
70 to 120 ml, right? And as we said, stroke volume depends upon the cardiac contractility and the venous return. So the blood pressure is basically the force exerted by the blood against the walls of the vessels. And why do we need the blood pressure? We need the blood pressure to maintain organ perfusion. Let's say in hypotension, what happens that the organ perfusion is decreased. If somebody has a blood pressure which drops below a particular level, there might be organ dysfunction. So what is hypertension? Hypertension is when the blood pressure is too high. And I would like to ask a question to any one of you. Can you tell me what is the normal blood pressure values?
120 by 80 mmHg.
By 80.
Okay. So what is high blood pressure?
The high blood pressure is above, the classification is there. It's above 140 by
Okay.
100
140 by?
100 mmHg.
Okay, by 100. Okay. Let me just take you through the classification. So if you see, this is the universal definition of high blood pressure. When the systolic blood pressure is more than 140 and diastolic is more than 90. Normal is less than 120, diastolic /80. Now, we have different recommendations, different guidelines. Physiology from the latest guidelines, 2017 guidelines from the American College of Cardiology, which tells us that normal blood pressure is less than 120 systolic and 80 diastolic. Elevated is 120 to 129 and the diastolic 80, less than 80. Hypertension stage 1, 130 to 139, diastolic 80 to 89, and stage 2, 140 or more than 90 millimeters of mercury diastolic. I would like you to just click a picture of you to focus on is only one. I don't want you to be in dilemma. So I would like you to focus on American College of Cardiology. I will tell you the reason later on why there is a discrepancy between two guidelines. But as of now, I would like you to concentrate on American College of Cardiology guidelines, which says that 120/80, below 120/80 is normal blood pressure, from 120 to 129 is elevated blood pressure, 130, 139 is stage 1, and more than 140 is stage 2. There's no stage 3 hypertension. Now, these are the types of hypertension. We have primary hypertension, secondary hypertension, isolated systolic, masked hypertension, white coat, nocturnal hypertension, resistant and refractory hypertension. I would like to ask any one of you who can answer me, what is primary hypertension?
Hypertension caused by unknown things, as in you don't know the cause of it.
Absolutely. So it's called idiopathic hypertension, and it's the most common cause of hypertension. It's also called essential hypertension. Pathogenesis is poorly understood, and genetic and environmental factors might play a major role. So around 90 to 95% of the people have essential hypertension. That means hypertension which has no pathogenesis. And most of the people, most of the people have primary, but we have to make sure that we don't underestimate secondary, which is probably around 5 to 8%. Now, primary hypertension there are risk factors of primary hypertension. So advancing age is incidence of hypertension. Family history is about, the hypertension is about twice as common in subjects who have one or two hypertensive parents. And race, hypertension tends to be more common, severe, and occurs earlier in life and is associated with greater target organ damage. Okay, so less than 120, less than 80. Elevated, which we don't take into the classification of hypertension, is 120, 129, and from 113 above is stage 1, 140 about stage 2. If we take into consideration, as I told you in the first slide, more than 140/90, then 32% of the population has hypertension. But as per the new guidelines from the American Heart Association, if we take 130 or 80 as stage 1 hypertension, this figure goes to 46%. You can see how by changing the guidelines, change the percentage of hypertensive population around the world. And then you can see here that with age, increasing age, the incidence of hypertension increases. And then with the race, if you can see again that the Black people are more prone to have hypertension. Now, this is as per the guidelines. When American Heart Association published these guidelines that 130 and /80, that is stage 1 hypertension, and this increased the people by 15%. So that means you have to treat these extra 15%, but we don't need to treat them. As per the guidelines, use of BP lowering medications is recommended for secondary prevention of recurrent cardiovascular disease events in patients with clinical CVD and an average blood pressure of 130 millimeters of mercury or higher, and for primary prevention in adults with an estimated 10-year atherosclerotic cardiovascular disease risk of more than 10% or higher. Let me explain to you guys in a simple terms. So if a person comes to you and he has no risk factor for heart disease and his blood pressure is 135/85, which comes as per the guidelines stage 1, his 10 years atherosclerotic cardiovascular disease risk is less than 10%. You don't need to treat him. You have to send him for lifestyle modifications. So anyone whose blood pressure is greater than 130 but less than 140 and has ASCVD risk of less than 10%, he doesn't need to have BP medications. So for them, lifestyle modification is recommended. Now, as you see here on the left side of the slide, you see there's COR, that is class of recommendation, and level of evidence. So can anybody tell me what does it mean? Okay, so class of recommendation means that if we say it's class 1, that means it's recommended, benefit outweighs risk. So green, you see the color is green and it says 1, that means it's highly recommended, benefits outweigh risk. And then LOE is the level of evidence, and the level of evidence here is A, and A means high quality evidence. So that means if we follow this guideline, it is highly recommended with high quality evidence. And I would like you to just take a picture of this. I would like you to go to this estimator. This is called atherosclerotic cardiovascular disease risk estimator, which will basically calculate the risk of a person to have a cardiovascular disease in next 10 years. Now, this is what I was talking about. So this is class of recommendation and level of evidence. So class 1 is strong, benefit outweighs risk, is recommended, is indicated, useful, effective, beneficial. And then we have class 2A, where there's moderate evidence. So it's reasonable. Here it's recommended. Here it's reasonable. And then the third class is class 2B, weak evidence, may be reasonable or might be considered. And then class 3, when it's not recommended and not indicated. And class 3, which again strong, here recommendation that risk is more than benefit, potential harm. So this is the class of recommendation on and the level of evidence. Level of evidence when it has been proven by high quality, by randomized controlled trials, it has been proven that there is high quality evidence that this treatment or this recommendation is going to help. Again, which I discussed with you, practical tips. You prescribe medication for stage 1 hypertension only if a patient has already a cardiovascular event, had a history of heart attack or a stroke, or is at high risk because of diabetes, chronic kidney disease, or he has more than 10% risk estimation as per the ASCVD calculator. Now, I would like to ask a question. What do we mean by primary prevention and secondary prevention? Anyone? Probably from MD4, if somebody is there. Okay, so
The prevention.
yes,
So
please.
primary prevention, which come before the illness, like the treatment before the, like we use as a prevention.
Right, Soumya, I think you're right. Primary prevention includes those measures that prevent the onset of illness. And secondary prevention measures leads to early diagnosis and prompt treatment of a disease, or to prevent more severe disease to develop. In more easy terms, anybody who doesn't have any clinical evidence of cardiovascular disease, we term them as primary. And if someone who already has a heart attack, then we call it a secondary prevention, not primary. I think it's clear, right? Now, secondary hypertension, as you said, the primary hypertension is idiopathic when there is no obvious cause. Secondary, there is a cause. So secondary hypertension has an identifiable cause. So these are the common causes of secondary hypertension. What you have: renal parenchymal disease, renovascular disease, primary aldosteronism, obstructive sleep apnea, drug or alcohol induced. And then there are further uncommon causes of secondary hypertension. Okay, so can anyone just give me an idea how you will suspect that a patient is having secondary hypertension rather than a primary hypertension?
By taking his history, personal history regarding his he's alcoholic, by seeing whether he's obese, or by history we can identify whether he can have a secondary hypertension related to these conditions.
Rakesh, you are absolutely right. Just to let you know that history taking and physical examination will give you 90% of the diagnosis. You don't have to be genius in diagnosing a particular disease. 90% of your job is done if you have a good history taking and a good physical examination. Believe me, I'm seeing patients in and out every day. And if you have a good history taking, a good physical exam, and then on top of it, there are investigations which you can order, will completely take you to a diagnosis. Now, if you see here, that's the algorithm of for hypertension. If somebody has a new onset or uncontrolled hypertension, drug-resistant induced hypertension, aberrant onset of hypertension, a person who has hypertension before the age of 30 years, exacerbation of previously controlled hypertension, disproportionate target organ damage for degree of hypertension, accelerated hypertension, onset of diastolic hypertension in adults more than 65, or unprovoked or excessive hypokalemia. So if you have one of these conditions around, then you should screen for secondary hypertension, and it's class 1A indication. So again, question to my students: what is class 1? We discussed about the class of recommendation and level of evidence. So what is class 1? Okay, so
benefits outdo the risk.
Absolutely. So that means it's highly recommended. That's what it means. So if you have all these, one of these factors around, and the blood pressure is uncontrolled, so you should think about secondary hypertension, and you should screen a patient for secondary hypertension. Okay. Now, third one is white coat hypertension. This is one of my favorite types of hypertension. Anyone from you can tell me about white coat hypertension? What is white coat hypertension?
Sir, when patients see doctor, so he like attends nice. That is the white coat hypertension.
Absolutely. I think you are right. You are the right. You have the right answer. So white coat hypertension is elevated of his blood pressure measurements and normal ambulatory blood pressure measurements or normal home monitoring blood pressure measurements. Can anyone tell me what is ambulatory blood pressure monitoring?
The ambulatory blood ambulatory monitoring. Our we are moving, just we want to check the blood pressure. At that time we can check the blood pressure because ambulatory is a movement. And it's like blood pressure is mainly like sometimes in hospital they will set a machine so it can detect your blood pressure for 24 hours. But
ambulatory blood pressure monitoring is a device which basically you have to fix when a patient comes to a clinic when you are suspecting that he is having white coat hypertension. You fix it. He takes the machine with him for 24 hours, and that machine measures the BP every 30 minutes to 1 hour. And after 24 hours, it gives you an average, all the readings, average reading, daytime reading, and nighttime reading. This is ambulatory blood pressure monitoring. And then there's home blood pressure monitoring when the patients at home check their blood pressure on the device, on the blood pressure device. The next type of hypertension is masked hypertension. Let me select one here. I just saw Shivani was there. So Shivani, can you tell me what's masked hypertension?
So it is a condition where the blood pressure is taken in the like home, and it is above than like it get above, and when it taken in the doctor's office,
you're absolutely
it is
right, Soumya. So masked hypertension is a condition where a patient, when he arrives to the clinic, his blood pressure is normal, but he says that when he's at home, the blood pressure, when he comes to the clinic, the blood pressure is normal, and when he goes out, he's out of the clinic and he's at home, we do an ambulatory blood pressure monitoring or home blood pressure monitoring, his numbers are high. So that's called masked. Mask is a mask. It masks his hypertension, which is the most, it has similar mortality rates as with systemic hypertension when you have persistent hypertension. So prevalence of white coat hypertension ranges from 15 to 35% in some populations. And masked hypertension, the risk of cardiovascular disease and all-cause mortality is similar with sustained hypertension. So masked hypertension is more likely to cause CVD rather than white coat hypertension. So this is an algorithm again. If somebody comes with, when you're suspecting a white coat or a masked hypertension, how you should evaluate your patient. I will not go through this slide, but I'll tell you what I usually do in my clinics. Let's say a patient comes to me, he's around 40 years of age and no past medical history. And we check his blood pressure. His blood pressure is 140 or 90. So what happens that the nurses are the one who check the blood pressure, who do the initial triaging. And after that, when he comes to my clinic, I see the blood pressure 140/90. So I usually go systematically. So I'll talk to him, discuss about him, what's happening around, take a detailed history and physical examination. And then by the end of the clinic, I will check his blood pressure once again. And by that time, usually in most of the patients, the blood pressure is normalized. So they come running, they want to see the doctor, they have missed their transportation, they had a fight outside at the reception, they come, they're angry, their BP is high. So that's most important thing is you have to recheck the blood pressure at the end of your clinic. So when the blood pressure is 130, 80 above and less than 160, 100, and you suspect that the patient has white coat, so you order a daytime, you order 24 hours ambulatory blood pressure monitoring. If the 24 hours ambulatory blood pressure monitoring shows average reading of less than 130/80, then we know that this is a white coat hypertension. We advise lifestyle modification and then annual BP monitoring and home BP monitoring to detect the progression. And if the blood pressure is more than 130/80 on the ambulatory blood pressure monitoring, we definitely, lifestyle modification is number one. We advise for lifestyle modification and start antihypertensive drug therapy if indicated. Now, I just want to ask, what is the indication? The guy is 40 years old, male, no past medical history. His blood pressure average on ambulatory blood pressure monitoring is 135/85. Who will treat the patient with antihypertensives and who will not? The question to all of you.
I won't, sir.
Why, Tejas?
Because sir, his blood pressure is regularly normal, but when it might be a masked hypertension, like how he came, not masked, sorry, might it will.
No,
it
Tejas,
will hypertension.
if you have gone through my slides, and I told you about it, that his blood pressure was more than 130, 140, or 90 when he came to me. But when we did the ambulatory blood pressure monitoring, his blood pressure is 135/85 average. So as per the American College of Cardiology, what stage is it?
As per even like I followed before JNC 7, as per JNC 7 also it's a pre-hypertensive stage, which is
So,
120
Tejas,
by
that's what we discussed about, that we follow the latest guideline. And as per the latest guidelines, which I discussed with you, 135 or 85 is stage 1 hypertension.
Yeah.
And my point is, do we need to treat this guy who is 40 years of age? He doesn't have any comorbid conditions. Does he need a medical management or not?
No, sir. He needs
No, sir.
lifestyle
He needs just lifestyle
modifications.
Okay. Anybody who agrees that he needs antihypertensive medications?
If it continues after some point of time.
Some point, how long?
After 50s.
No. I think the age, there's no age criteria here. There's no age criteria here. The issue again is if a person has stage 1 hypertension, as per the American College of Cardiology, and then his ASCVD score is more than 10%, or he has diabetes, chronic kidney disease, or established cardiovascular disease like stroke, coronary artery disease, then is the time when you start these patients on antihypertensive. Otherwise, you need not to start these patients on antihypertensive. You continue them on lifestyle modifications. And similarly, we have masked hypertension. Again, you have to suspect a patient to have a masked hypertension. Then you order a daytime 24 hours BP monitoring. If the blood pressure is more than 130/80, but the clinic BP is less than 130, that's masked hypertension. Here, the question is, do you need to start antihypertensives? And as per my clinical practice, if a patient has target organ damage, if you remember my previous slide where I mentioned about disproportionate target organ damage for degree of hypertension. If you see this. So basically, this point you have to keep in mind. A person who has normal blood pressure during the office hours, ambulatory blood pressure monitoring shows hypertension, and then he has target organ damage, I will definitely start him on antihypertensive medication because he already has a target organ damage. My question to everyone once again, what is target organ damage?
The specific organ is damaged due to the hypertension.
Absolutely. So target organ damage is basically, I'll just go forward few slides to show you the target organ damage. Sorry for this. Okay, so this is target. So blood pressure, when you have blood pressure, it affects certain organs of the body. So it can cause hypertensive retinopathy, it can cause cerebrovascular disease, coronary artery disease, renal disease, and peripheral artery disease. So these are all target organ damage. So if a patient who has normal BP at my clinic, but has high blood pressure on ambulatory blood pressure monitoring, I would prefer to start him on antihypertensive medication if he has target organ damage. And target organ damage, as we said, that it's retinopathy, hypertensive retinopathy, cerebrovascular disease, coronary artery disease, peripheral arterial disease, and renal impairment. Okay. Next slide. As we discussed, I told you about lifestyle modification. So these are the lifestyle modification we have to emphasize the patient on. Believe me, I have been practicing for almost 18 to 20 years now. And the first and foremost thing which I tell my patients is lifestyle modification rather than medication. And it has a causal effect on their blood pressure measurements. I'll tell you later in my slides how does it improve the blood pressure readings. So then we have resistant hypertension, hypertension that remains uncontrolled despite 3 antihypertensive medications, including a diuretic, or blood pressure that is controlled on 4 antihypertensive medications. Association of resistant hypertension, old age, black race, left ventricular hypertrophy, chronic kidney disease, obesity, and diabetes mellitus. How do we treat resistant hypertension? Aggressive lifestyle modification, as we discussed earlier, that you have to ask the patient to go for exercise, diet, weight reduction, give up smoking, limit alcohol, control your other risk factors, and stress management. So basically, before you evaluate a patient with resistant hypertension, you have to make sure that there is no contributing medications or factors which is basically not letting his blood pressure to get controlled. And then you have to add a mineralocorticoid antagonist to treat a resistant hypertension. My question to you is, what is a mineralocorticoid antagonist? Can you just name one?
Thiazide diuretic.
No,
Sorry,
that's a diuretic. I'm talking about mineralocorticoid antagonist. Okay, spironolactone is the one which is one of the mineralocorticoid antagonists. So this is the algorithm of the evaluation, diagnosis, and treatment of the resistant hypertension. You can go through it, take a picture. You have to go with every part. But most important thing in resistant hypertension is to make sure that you exclude pseudo-resistance. Pseudo-resistance means that you make sure that the BP you are checking is accurate and the measurements are accurate, and you make sure that the patient is compliant with his medications. He takes his medications regularly, and make sure that it's not, white coat effect. You have to make sure that he doesn't have white coat hypertension. So if you exclude all of these, then you think that this might probably be a resistant hypertension. Then you identify a reverse contributing lifestyle factors, discontinue or minimize interfering substances, and then screen for secondary causes of hypertension. And then you basically start with optimizing the pharmacological treatment. Blood pressure, which remains uncontrolled despite 5 medications of different class, including a diuretic and mineralocorticoid receptor antagonist, is called refractory hypertension. Every 20 millimeter mercury higher systolic and 10 millimeters of mercury higher diastolic blood pressure, the risk of the death from heart disease and stroke doubles. I would like to stress here that the prognostic significance of systolic blood pressure and diastolic blood pressure as a cardiovascular risk factor appears to be age dependent. The systolic blood pressure and the pulse pressure are greater predictors of risk in patients over the age of 50, and under the age of 50, diastolic blood pressure is better predictor of the mortality. Now, as I discussed with you initially, that the history taking and physical examination is the cornerstone in diagnosing any disease. Any disease. If you have a good history taking, a good physical examination, you're almost done with your diagnosis. And then, in addition, your diagnosis will be supplemented by laboratory testing and additional testing. History taking, duration of the disease, how long the patient is having symptoms, or how long the patient is has been seeing that his BP is high. Were there any attempts made previously to treat the blood pressure? You determine the precipitating or aggravating factors, including prescription and non-prescription drugs. You see the extent of target organ damage, and you evaluate the risk factors for atherosclerotic cardiovascular disease. My question again to you guys is, what are the medications that might impact and cause high blood pressure? Anyone? Okay, so NSAIDs, non-steroid anti-inflammatory drugs, they are one of the few of the medications which can cause hypertension. Antidepressants, corticosteroids, hormones, estrogens, androgens, they are all can cause hypertension. And that's why you have to make sure that the people who have resistant hypertension, you make sure that they are not on one of those drugs. You don't want to give them medications and at the same time they are on these medications which is not letting the blood pressure to get under control. So basically you have to have a good history to make sure that the patient is not on these medications, and that's probably that, and exclude the other causes of secondary hypertension. Physical examination, you have to evaluate for the signs of target organ damage. We discussed about target organ damage, what are these, and look for evidence of potential causes of hypertension. So aspects of physical examination. General appearance, distribution of fat, skin lesions, muscle strength, alertness. It might give a hint about secondary hypertension. Fundoscopy, hemorrhage, papilloedema, cortical spots, arteriolar narrowing and AV nipping. If you have any idea about hypertensive retinopathy, so these are the stages where you can find the changes because of hypertension. Then you palpate the neck, see, auscultate the carotid, see if there's any bruise, heart, size, rhythm, sounds. Check the lungs for any bronchial abdomen for any renal masses, bruise or aorta and renal arteries, femoral pulses and extremities for peripheral pulses and edema. And then in addition to it, you can the additional laboratory testing can help you in coming to your diagnosis. Just to relax your eyes from my slides, this is Dubai. This is Burj Khalifa. It is the tallest tower in the world. Believe me, I'm here for the last 12 years in Dubai, but I haven't been there once. So for me, it's very difficult. I go to the hospital and come back, and I have seen it, but I haven't been there inside the building. Okay, so additional testing. Urinary albumin creatinine ratio. Albuminuria is an independent risk factor for CVD. So as we discussed, albumin, as we discussed about the target organ damage, and we know that if you have target organ damage, that means already the hypertension is persistent and has been there for a pretty long time. So you have to make sure that you evaluate any target organ damage. So albuminuria is very simple. It's a very simple test of having urine analysis done and checking the urine for albumin. So if you find albumins there, that means his kidney has already been impacted by high blood pressure, and you have evidence of target organ damage, and you need to treat it. Similarly, echocardiography is an ultrasound of the heart, which also will tell you about the functions of the heart, whether the patient has left ventricular hypertrophy, is there any evidence of systolic or diastolic dysfunction that might be contributing towards, that might be suggestive of target organ damage. I got this slide from one of our med reps, and if you see microalbumins is a risk factor for cardiovascular disease, and the more the secretion of albumin in urine, the more of chances of getting, the chance of CVD gets higher. This is the cardiovascular mortality. If you have microalbumins, what happens over the follow-up years? The more you have proteinuria, the more chances of you of getting CVD and mortality. Now, as we discussed about the conditions where you can presume or think that the patient has having a refractory or resistant hypertension, but we're missing the proper way of measurement of the blood pressure. So this is what are the guidelines. The guidelines say, as I said again, there's the class of recommendation, the level of evidence. It says for diagnosis and management of high blood pressure, proper methods are recommended for accurate measurement and documentation of blood pressure. So what are the proper BB measurements? So you make the patient prepare properly, use proper techniques, take the proper measurements need for the diagnosis, properly document accurate BP readings, average the readings, and provide BP readings to the patient. And then again, if somebody is very obese, you cannot use a small adult cuff on him. So you have to use a cuff size as per the arm circumference. So these are the few tips how to take the blood pressure: refrain from caffeine, smoking, and exercise. Sit on a chair with the back supported, arm rested for 5 minutes. Ensure that the patient has emptied his or her bladder. Remove the clothing covering the area where the cuff has been placed. Use the correct size cuff. Position the middle of the cuff at the level of the right atrium, and take at least 2 measurements and separate them by 1 or 2 minutes. You can imagine that if somebody has his or her bladder filled, the BP will go up. So just imagine how important it is for you to take a blood pressure measurement properly. And this is the cardiovascular continuum. Somebody having hypertension, diabetes, he starts getting endothelial dysfunction. Then gradually atherosclerosis, left ventricular hypertrophy, microalbuminuria, which is the target organ damage, coronary artery disease, myocardial ischemia, coronary thrombosis, myocardial infarction, remodeling, systolic dysfunction, and heart failure. Okay, so this, I just forgot to tell you that I deal with most of the time with preventive cardiovascular medicine. I would like to know, and this is a question for everyone, what are the modifiable risk factors? Anyone?
Pardon, sir?
What are the modifiable risk factors? It's on your screen.
Smoking.
So the risk factor that we can change by our
Absolutely, absolutely. So there is factors which can change
like
this.
ASX, which we can't change them.
Absolutely, those are okay. So, there are non-modifiable risk factors are age, ethnicity, and sex. And non-modifiable risk factors are age, ethnicity, and sex. And modifiable risk factors are obesity, smoking, hyperlipidemia, hypertension, diabetes, and physical inactivity. And if you see how hypertension, which is one of the modifiable risk factors, how much the mortality is increased by only this modifiable risk factors: tobacco, high cholesterol, underweight, high BMI, unsafe sex, physical inactivity, alcohol. They all, have, they're all modifiable basically, but the mortality is high with hypertension. So you should imagine how important it is for you to address anybody having hypertension. And this is the population effect of blood pressure reduction and mortality. By decreasing just 5 millimeters, you decrease stroke by 14%, coronary heart disease by 9%, all-cause mortality by 7%. So if you decrease systolic BP by 2 millimeters, and you can see how much significant effect it has on mortality. Okay, so non-pharmacological interventions. Non-pharmacological interventions, as I said, for me, they are the lifeline. They're the most important. I emphasize more on non-pharmacological interventions rather than medications. And believe in me, my experience shows that persons who adhere to non-pharmacological interventions, rarely I have to start them on antihypertensive medications. Most of the time, they get controlled with non-pharmacological interventions. So diet, as we discussed, and we'll discuss later on as well, physical activity, weight reduction, smoking, alcohol, stress management, and other risk factors, they all come under the banner of lifestyle. And as per the guidelines, weight loss is recommended to reduce the blood pressure in adults with elevated blood pressure or hypertension. Basically, everyone who has high blood pressure or has elevated blood pressure needs lifestyle modification. Weight loss, DASH diet, which is very important. I should tell you that DASH diet has been shown to decrease the CAD, coronary artery disease, and stroke risk by 21%. Then you have sodium reduction, potassium supplementation, increased physical activity, and restriction of alcohol intake. So if you see this slide, very important slide, you see how these measures of non-pharmacological interventions decrease the blood pressure, and by significant, if you see, weight loss itself will decrease the blood pressure by 5 millimeters. Healthy diet by 11. If you decrease the sodium intake by 5 to 6 millimeters. And then if you do aerobic exercise, dynamic resistance exercise, isometric resistance exercise, and alcohol consumption, if you add on, you will see if a person has a blood pressure of more than 150, if he follows all these lifestyle changes, his blood pressure will normalize. The DASH diet I was talking about, which decreases, which has 20% reduction of the mortality. You see this is included in DASH diet, and you should emphasize this diet for all the patients who have hypertension. Physical activity, as per the guidelines, 150 minutes of moderate intensity exercise or 75 minutes of high intensity exercise is recommended for keeping a healthy heart. So high intensity exercise, football, rugby, skipping rope, hockey, jogging, aerobics, gymnastics, and moderate intensity exercise is brisk walking, pushing a lawnmower, hiking, skateboarding, rollerblading, double tennis. These are all moderate intensity exercise. And how these exercises have effect on the heart, you can see it has a psychological, anti-arrhythmic effect, anti-thrombotic effect, anti-atherosclerotic, and hemodynamic effects on the body. It improves exercise performance, improves endothelial functions, has endothrombotic effect, improves fitness level and thereby quality of life, decreases myocardial oxygen and reduces myocardial ischemia, improves myocardial perfusion, helps maintaining ideal body weight, improves glycemic control, and increases HDL cholesterol. So many benefits of exercise. Then we come to the pharmacological interventions for blood pressure treatment. ACE inhibitors, ARBs, calcium channel blockers, beta blockers, diuretics, alpha blockers, and centrally acting drugs are few of the classes of antihypertensive medications which we recommend to the hypertensive patient. I would like to ask, because I had a little conversation with one of you, what are the diuretics? Can anyone name few diuretics?
As I
Yes, Shilpa.
Furosemide.
Okay, what kind of diuretic is furosemide?
Loop diuretic.
Very good. What about hydrochlorothiazide?
Thiazide.
What about indapamide?
Thiazide.
Thiazide diuretic.
Absolutely. What about triamterene and amiloride?
Potassium sparing.
Absolutely. You're absolutely spot on. Anything about ACE inhibitors? Anyone?
Subtrils, Ramapril,
Captopril.
Absolutely. What about ARBs?
Losartan.
Absolutely. And one central acting drugs. Anyone?
Methyldopa.
Absolutely. And I would like the doctor who asked about methyldopa, what is the strongest indication of methyldopa?
Usually not to give it to male because of erectile dysfunction.
No, who you will advise methyl dopa?
Pardon?
What is the compelling indications of methyl dopa? Who will give methyl dopa?
Pregnancy.
Absolutely right, Tejas. You are absolutely right. Okay, so again, this is the BP threshold. BP threshold, as per the guidelines, use of BP lowering medication is recommended for secondary prevention of recurrent cardiovascular disease events in patients with clinical CVD with blood pressure of more than 130 and diastolic more than 80, and for primary preventions who have 10 years risk of more than 10%. If the patient has less than 10% and his blood pressure is between 130 and 140, and he doesn't have clinical CVD, he doesn't need treatment. Okay, so this is an algorithm, a quick algorithm. Normal blood pressure, less than 120/80, promote optimal lifestyle habits, reassess in 1 year. Elevated blood pressure, non-pharmacological therapy, reassess in 3 to 6 months. And then you see stage 1 hypertension. If you have clinical ASCVD or 10 years risk more than 10%, yes, then you have to start non-pharmacological therapy, as I said, lifestyle modification and BP lowering medications. If it is less than 10%, no clinical CVD, only non-pharmacological therapy. Adults with elevated blood pressure or hypertension, you need to follow up after initial BP evaluation, and as per the recommended guidelines, you have to have a repeat BP evaluation within 3 to 6 months. The people who have stage 1 hypertension and who have ASCVD risk of less than 10%, lifestyle modification, no medications, and re-evaluate in 3 to 6 months. The people who have more than 10% or have or on antihypertensive medications, repeat evaluation in 1 month. And again, what are the recommendations for the choice of antihypertensives? The first line is calcium channel blockers, ACE inhibitors, ARB, and diuretics. These are the first line antihypertensive medications, but again, we have to give the medications as per the clinical scenario. We have sometimes compelling indications where you don't give the first line treatment. And I would like to ask, what are the compelling indications for prescribing antihypertensive medications? Anyone? Okay.
Can you repeat again?
Yes, Tejas.
Can you repeat again?
As you see on my slide, that these are the first line medications. They have been shown and proven to be very beneficial and should be used as a first line for anybody who's having hypertension. But there is something called compelling indications, where you have to see a clinical scenario and you can change the first line and give something else. So what are these compelling indications?
Just like
So
a
kidney
pregnancy.
disease
Absolutely.
and diabetes.
Absolutely. So if you have diabetes, kidney disease, you try to prefer ACE and ARBs. Let's say you have heart failure. So what will be your first choice?
Beta 1 agonists.
Thiazide.
What is beta 1 agonist?
Propranolol.
Okay, so basically beta blockers. Absolutely right. So beta blockers can be given in those patients or who have compelling indications like heart failure or atrial fibrillation. Now, my question is there any difference between propranolol and metoprolol? Anyone?
Yes.
Propranolol is beta 1 and beta 2, means it's non-selective, and metoprolol is beta 1 selective
Absolutely.
antagonist.
So what is the difference between selective and non-selective?
Selective acts only on the specific receptor.
Absolutely. So if you have a patient who has asthma, are you going to give him propranolol?
No.
No, sir.
Absolutely, absolutely, Neha, you are absolutely right. Okay, so just to go ahead, multiple antihypertensive agents are needed to reach BP goal. If somebody has a blood pressure of more than 140/90, which is stage 2 hypertension as per the guidelines, you can see there, these are all the studies which have been done so far. And if you see, around 23 to 54% of the patients with hypertension require 3 or more drugs for their BP control. So one drug is not sufficient in most of the cases. What are the best combination of the antihypertensive medications? As we discussed, and you can see here, the green lines are the best combinations. So the green lines, which are, you can see between thiazide and ACE inhibitors, and between ACE inhibitors and calcium channel antagonists. They are preferred combinations. And then there are a few which are unpreferred, and there are a few which are contraindicated, which is ACE and ARBs. If you give together, that's an absolute contraindication. And then we discussed about the compelling indications. If somebody has heart failure, elderly patients and systolic hypertension, we tend to give them diuretics. Somebody has angina, post-MI, has arrhythmias, heart failure, we try to give them beta blockers. People who have angina, diabetes, and cardiovascular, CVA, cerebral vascular disease, calcium channel blockers, and then ACE inhibitors in people who have heart failure, LV dysfunction, proteinuria, and then you have contraindications where you should not prescribe these medications. Adults initiating a new or adjusted drug regime for hypertension should have a follow-up evaluation of adherence and response to treatment at monthly intervals. As I said again, that most important thing is compliance. If the patient is not compliant, you will not achieve the target. If you not achieve the target, you will not be able to control the complications of hypertension. What is the BP threshold and what are the goals? If you see, these are the latest guidelines. As per the latest guidelines, the goal for everyone is less than 130/80. Whether the patient has diabetes, chronic kidney disease, heart failure, ischemic heart disease, peripheral artery disease, stroke, everything, the blood pressure should get down the blood pressure to less than 130/80. Okay, so this is the last slide. Take home message. Hypertension is the major cause of premature death worldwide. Hypertension is a modifiable risk factor. Values above 130/80 millimeters of mercury of hypertension is hypertension. So anything more than 130, more than 80 is hypertension. And here again, I would like to repeat, I like to repeat things many times so that you just grasp it and you don't forget it. 130 and 80, less than 140/90, no clinical ASCVD, less than 10% risk estimation, no treatment required. Start lifestyle modification. Non-pharmacological intervention plays a major role. Most of the patients would require more than 2 antihypertensive medications to achieve the target, and target goal in most of the patient is less than 130/80. Thank you very much. And thank you for having me today.
Thank you, sir. Thank you very much. It was indeed a very, very educative talk. And I'm sure, like me, all of you enjoyed it. If you have any questions, any clarifications, please ask. Okay, if you don't ask, then I threaten that you will be asked questions. So please ask.
So,
yeah. Yes, Rosemary.
Yes. So in a case whereby you've been managing a patient with hypertension, okay, and you have alternated all the drugs, you have alternated all the combination and changed the person, and the therapy is not working, and then maybe probably ruled out a few other probable causes. So what would be your best way to manage this patient, more like a resistant person to drug?
Absolutely. No, I have many patients who come like this. Let's say a patient comes to my clinic and then his blood pressure is high, he has stage 2 hypertension. I start him on a combination of ACE inhibitors and calcium channel blockers. And then I usually follow him initially. After a couple of weeks, I'll tell him to come back. Then he comes after a month. If he doesn't have the blood pressure is controlled, then after excluding that there is no pseudo resistance, that he is compliant with his medications, that he has started his lifestyle modification. If everything I have ruled out and I see that my blood pressure readings are fine, and I'm pretty sure that everything is going as per my recommendation, I would try to maximize the dose of those two antihypertensives. So if I have given a dose of ramipril and a calcium channel blockers, I will try to maximize the dose and then get him back in a month's time. It's very important to note that it's never that you don't have to be very aggressive in getting down the blood pressure, because if somebody has target organ damage, he has persistent hypertension for a long time, try to get it down. The body is already used to high blood pressure, and you don't want the blood pressure to get down too quickly. That will not be good for him. So try to get the blood pressure over a period of time if he has had a blood pressure for a long time.
Okay, thank you, sir.
Sir,
yes, Tejas.
So you said that beta 1 blocker we can use for heart failure.
Absolutely, beta blockers.
Sir, but if like beta 1 blocker will reduce the cardiac output, then
Absolutely.
the symptoms will be worsening.
Very good question, Tejas. That's a very nice question. If you see the guidelines, beta blockers have mortality benefit on a patient who has heart failure. So it's not just to control the blood pressure, it has a mortality benefit. Beta blockers are given, I didn't go through that part of renin-angiotensin-aldosterone system, which is a huge topic. Basically, beta blockers have been advised and recommended to all the patients who have heart failure. They compensated heart failure, and he's on beta blockers. We try not to wean him off the beta blockers. We might just decrease the dose of beta blockers and keep him on beta blockers, because that has a mortality benefit. But definitely, if somebody has an acute heart failure, we need to reduce his congestion. We try to give him ACE inhibitors, diuretics initially, and we might withhold his beta blockers and then reintroduce it as soon as he stabilizes.
Thank you, sir.
So,
yes, Neha.
A female patient with the age of 47 or 48 with a chronic hypertension and a condition of kidney cyst, what are we supposed to give the first line defense of medication to that patient, sir?
Kidney cyst has nothing to do with hypertension. If his urea creatinine are fine, if his renal parameters are fine, you can start him with the first line treatment. You don't need to see anything. If his renal functions is deranged, then you might have to see what is causing the renal dysfunction. Renal cyst, I don't think causes any renal issues until there are some parameters which are abnormal.
So, can hypertension be a reason for cyst?
I cannot answer this question, Karen. I haven't seen anybody who's hypertensive. I have seen people who have incidental findings of renal cyst and they're hypertensive, but hypertension itself causing renal cyst, I have not come through across.
Sir, if somebody have only one kidney, then how could it affect blood pressure?
How could it affect it? See, again, as I told you again, even to survive and have a normal life, one kidney is enough. And if you have the right parameters, let me give you a different example. A patient who have chronic kidney disease and have impaired renal functions, we do start them on ACE inhibitors, because ACE inhibitors are thought and have been shown to have a lot of benefit, even if the patient has renal dysfunction. The people who are diabetic have renal dysfunction, we will give them ACE inhibitors. They definitely have a lot of benefit. But if because of these ACE inhibitors, the renal parameters derange, they get worse, more than 25%, if I'm not mistaken, then probably you have to switch them to a different medication.
Sir,
Thank you, sir.
Yeah, please carry on.
Sir, I have one question. If a patient came to you and you check his or her BP and it is very high, like it's very, very high. So what can we do in this case? Because if it's very high, then it can rupture the brain arteries and other arteries also. So what is there is a precautions we can take over that time, or any
See,
medication we can give?
very high. What do you mean by very high?
Like, sir, I go
Probably
to a clinic.
I have to give a different lecture on that. We have something called hypertensive urgency and hypertensive emergency. Then you have to act differently. We're talking about blood pressure grade 1 and grade 2. If somebody has blood pressure of 220 and he has evidence of acute and organ damage, then you have to get that BP immediately down. But again, there are certain protocols, how much you have to get that BP down in a particular time. Somebody has a stroke, you have to be very gentle in getting the BP down, but somebody has pulmonary edema, has heart failure, aortic dissection, let's say, then you have to get the BP down immediately.
I seen a patient who have a high BP problem, and why I'm sitting in the clinic, he having high BP. So one doctor gave him a medicine, and the BP falls and make him to normal. So what the medication he gave that time? I want to know that thing.
See, I don't know what medication he might have given, but he might have definitely given some antihypertensives. If he had a cannula, he might have given some IV medication to get the BP down. But as I said to you again, that if someone, let's say someone comes to my clinic, I'll give a real-time example. If somebody comes to my clinic, his blood pressure is 210 systolic by 110, and he is fine, and he says, I'm fine, I don't have any symptoms, I don't have complaint, I will not even admit him, I'll send him home. I'll start him on antihypertensive. I'll just do the basic evaluation, good history, make sure that he doesn't have any target organ damage. If he has, send initial testing as I showed it in my talk, and then just start him on two antihypertensives and send him home and get him back in a couple of days and see how he's going.
Okay, sir.
Any more questions? Any more questions? Arun,
Sir,
can you hear me?
Anybody that have the baseline blood pressure is around 110 by 70, then what that time how we can say that it is in the condition of hypertension?
No, 110/70 is normal blood pressure. 110/70 is not blood pressure. 110/70 is completely normal blood pressure. Any blood pressure which is less than 120/80 is a normal blood pressure.
No, sir, 170 if it goes to 120, can it affect his body by increasing 20 mmHg?
This is within the normal range, right? If somebody has a 90 or 60 blood pressure and it goes to 120 or 80, he still fits in normal range. You don't need to do anything. It's, as I said that again, and I want to repeat it, we go by an individual. We treat an individual. We never treat numbers. Just keep that in mind. We don't treat numbers. We treat an individual. And we tailor our recommendations, we tailor our medications as per the particular clinical scenario.
Any more questions? Any more
Sir,
questions?
Yes, please.
Sir, is there is a possibility that normally we are saying that blood pressure is 120/80 normally in the person we are normally taking. Is there is a possibility that some person I heard that they have less BP and it is common for them?
Absolutely, that's what I said.
Like,
that we see an individual, we treat an individual. There are people who have blood pressure of 100 systolic and they are doing fine. So if they are doing fine, you don't touch them at all. That means they are perfusing well. If they are symptomatic and they have syncope, they fall down, they have loss of consciousness, then yes, then you need to treat them. But otherwise, if somebody is fine, his blood pressure is 100, that's fine for him. That might not be fine for someone else, but that's fine for him. So if it's fine, he's asymptomatic, we don't touch the patient.
Then in that case, how we recognize the patient that he has or she has a BP, high BP or low BP or hypertensive in that case?
As I said in my slides, everything above 120 is high blood pressure. Below 120 is normal blood pressure. A patient has 110, this is normal. The patient is 100 systolic and he's fine, he's not symptomatic, this is normal for him. Now, if he is 125, 130, then you start thinking about high blood pressure. Less than 120, you don't need to think about it.
And in case of low BP, sir, if like a person having 70, then
see, a patient who will have 70 systolic blood pressure, he will not be roaming around. He will have syncope. He will be having loss of consciousness. So that's a completely
the symptom, just symptom will show us.
Absolutely, absolutely. You will not see a person who has 70 systolic BP walking to you in the clinic.
Yes.
Yeah. So there is a map, which we call it mean arterial pressure. If somebody has a 70 systolic and diastolic is around 50, 40, his map will be very low. He will not be standing in front of you.
Okay, sir. Thank you, sir.
Any more questions?
Sir, I have one question.
Yeah.
Hello? Yes, please. Go ahead.
Sir, the one guy's age is around 20 years old. His BP is because he's just modifying his. He was obese, but he is modifying his exercise and his lifestyle. But it is possible these things means he will get organ damage quickly, or he has to go aggressively, sir.
No, see, you're absolutely. It's a very good question you're asking. You know, there are a lot of people who are very young, and as you said, that they have some identifiable risk factors for hypertension, and in this case, in your patient, you said obese. What I personally do in my clinic, if somebody comes and he has blood pressure of 140, 80, or 150, 90, I assess and I make. I think that it's probably because of his, let's say, obesity. I will not start him on medications if his blood pressure is not very high. If his blood pressure is in the range of 140s and 130s, I'm not going to start him, but I'll do a basic investigations to make sure that he doesn't have a target organ damage. If he doesn't have microalbumins, his ECG does not show left ventricular hypertrophy, there's no changes in his eyes, I might even send him for an echocardiogram to make sure that he doesn't have left ventricular hypertrophy. If I don't find any evidence of target organ damage, that means I have some time to follow him up on lifestyle modification. And if you remember my slide, I will get him back in next 3 months and reevaluate him for the need of any antihypertensive medication.
Thank you, sir.
Hello.
Yeah, please ask your question. Yeah.
Sir, as you said that hypertension is not directly related to kidney or renal systems, but in case of neonatal hypertension, the most common cause of hypertension is chronic glomerulonephritis. So how is it
I think you have not seen my slide. If you see my slides, I have the renal parenchymal disease is a cause of secondary hypertension. I have mentioned it. I think I can go back to that slide if I can find that slide immediately. I have written in my slide here that, just a second. Okay, here you go. If you see renal parenchymal disease on the top of the list. So I never said that this doesn't cause hypertension. We're talking about a renal cyst, not a renal disease, not renovascular disease, not renal parenchymal disease. We're talking about renal cyst.
Okay, sir.
And I want to ask you one question now. I just want to see that whether my lecture has done something, you have got some benefit out of it. This question is open for everyone. A patient comes to you, she she is a 26-year-old female, and her blood pressure is 180/120, and she has.
Sir, could you please repeat the question?
Absolutely, I'll do that. It belongs to you. 26-year-old female. She's saying that she's having worsened and her blood pressure is very high. Blood pressure is 180 or 120, and then she has left ventricular hypertrophy on ECG, and on examination she has an abdominal bruit. What's your diagnosis?
Renal artery stenosis will be there, sir.
Close by, not renal artery stenosis in a 26-year-old female. They have.
Or else will be around aortic aneurysm.
No, absolutely not.
Okay.
So we don't. I'm talking about high blood pressure, young female.
Aneurysm.
No. So the answer to this question is fibromuscular dysplasia. This is the most common cause of renovascular hypertension in young. Now let's say, I'll use a different example. You have a 60-year-old male who has worsening of hypertension, getting uncontrolled despite multiple medications. Again, on physical examination, you find an abdominal bruit. What's your diagnosis? I think here, the doctor who told me about renal artery stenosis, this comes into play. Here, a person who is 60, more than 60, he has risk factors, he has now uncontrolled hypertension despite being on multiple medications, and he has abdominal bruit. You think of renal artery stenosis secondary to atherosclerosis arteries. So that's how, as I told you, that physical examination and history taking will give you 90% of the diagnosis. So you have to see that a lady, 29, 26, very high blood pressure, abdominal bruit, she will not have atherosclerosis of the renal. So most common diagnosis here becomes fibromuscular dysplasia. And in 60 years old, who has been hypertensive, controlled, suddenly becomes uncontrolled, he has risk factors, most likely the diagnosis will be renal artery stenosis secondary to atherosclerosis.
Okay. Can you hear me?
Yes, sir.
Okay. Dr. Tamkeen, very much for an excellent talk. I think it was very interactive, and I can see that the students benefited. They were not only asking you questions, but in the chat box, they were unfortunately sending questions privately to me.
Okay.
So anyway, I was answering those questions, but if you can spare, I will just share those questions with you, and I hope you will give the same answer I gave them. So, what is white coat hypertension? Is it a type of psychological hypertension?
It's not. You don't call it a psychological hypertension. There are people who, I mean, psychology is a very broad term, but are the people who get anxious as soon as they. It's not that they see a white coat. I don't wear white coat at all in my clinic. But as soon as they enter the premises of the hospital, they get a call, means surge goes on, and then they get frightened, they get anxious, they have seen a doctor, and their BP shoots up. There have been a lot of studies which have found out that they don't cause as damage as a sustained hypertension or a mass hypertension, a white coat hypertension. We try to take them initially with lifestyle modification, and if they don't settle down, yeah, long term we have to think of starting them on antihypertensives.
The next question was that there is a patient of age 45. She complains of pain, chest, and her past she has high cholesterol. Her blood pressure is more than 130/80 at home, and patient has hypertension.
We say that it's probably, as per the guidelines, stage 1 hypertension. hypertension. But in order to confirm that she has a hypertension, I would like to see her in my clinic. I will have take a, as I said again, a detailed history and physical examination, and I will order 24 hours BP monitoring, which basically will give me an idea about her blood pressure during the 24 hours, and then will help me in making my diagnosis.
Okay, I think I gave the same responses, so it's okay. Because I thought I would ask the same questions from you because they are sent to me privately.
Okay.
Dr. Tamkeen, thank you very much. A very, very nice talk. I enjoyed it. I'm sure the students would have enjoyed it too. And lot of us see learning is not related to age. So you are learning, I am also learning, and all of us learning from each other. So that should be the on a subject like Dr. Tamkeen has given. I know we cannot put our hands together for him in the usual manner, but I will clap on all your behalf for an excellent talk taken by Dr. Tamkeen. I know you all share my feelings and my sentiments when I say that. Dr. Tamkeen, thank you very much. And I've got lot of other feedback, sir. When can be his next lecture?
Dr. Pawan, I would like to thank you first of all that you invited me for the lecture today. Thank you very much. Thank you again to the administration of Lincoln American University, and thank you to the students. Believe me, when I saw their faces, as you said initially when the lecture started, please switch on your videos. I felt that I am sitting there. I remembered my own medical school days, same long hair, and tired look. So I felt that it's me, believe in me. And then when I made my slides, I probably gave probably around 15 hours in few days to make these slides, because I wanted to make them not for doctors but for students, so that they understand the basics. Because if the basic is clear, you can build up a big building like this Burj Khalifa on a strong foundation. So if you have a strong foundation, I think that's the main thing. And I would like to even, if it's fine for you, I can keep my phone numbers on WhatsApp with the university. If the students have any questions anytime, they can get directly in contact with me. They can come on talk. There's a new, we don't have WhatsApp working here with calls in Dubai. They're all blocked. So we have talk, which is basically I can have video chat. Anybody, anytime having any clarification about any cardiac related issues, I'll be more than glad to answer them anytime.
Thank you very much. We will, if you permit, there are two things the students have asked. One is, can you take more lectures for them? And the second thing is, they have asked whether we can share your PowerPoint slides.
Absolutely. They are most welcome to go ahead with sharing the slides, and then I'll try. It's a very difficult task for me because this pandemic going around in Dubai, everywhere in the world. We were very much busy, and as we know that these people who have coronavirus, COVID-19 infections, they have a lot of cardiac complications, and the cardiac complications are more in people who are hypertensive. In Italy, around 75% of the people COVID-19 were hypertensive. Pathogenesis of it is a new disease, but most of these COVID-19 patients have cardiac complications. So very much busy, but definitely if there's a particular topic where I can come and give a chat, give my talk, I'll be I'll be thankful to do that, and anytime. But you'll have to just give me a certain period of time to make the slides and tailor them according to the needs of the students.
Thank you very much. It was indeed a privilege to listen to you.
Thank you very much, sir. Thank you very much, sir.